Hello, welcome to our Being Patient community. I'm Deborah Kahn, founder of Being Patient. We are going to talk about early signs of Alzheimer's. It's a topic that keeps coming up. A lot of you have questions about it. One of the most common we get is how you tell the difference between early stage Alzheimer's and just normal aging. So it was great to bring back with us Dr. Jason Karlawish. He joins us from the University of Pennsylvania. He is the author of this book called The Problem of Alzheimer's, which I am reading right now. Highly recommend it. Because Jason combines both, his clinical research, seeing patients, and also offers a lot of history in the timeline of Alzheimer's, how it evolved, and some of the key players. So Jason, great to see you again, and thank you so much for joining us.
Thanks, Deborah. It's great to be back on Being Patient.
Okay, so I want to start first with one of the things that really kind of caught my attention is the topic of detecting and treating Alzheimer's before really symptoms set in. I liked some of you relayed to us in the book, some how you diagnose, some with conversations that you've had with patients, stories about the onset of Alzheimer's. So let's start at the very beginning there with the very basic question. How early can you actually diagnose Alzheimer's?
Right now in 21st century America, I think we are still at this point where we can diagnose the disease because you have some cognitive problems and we can push the limits of tests that show that you have the biological markers of the disease. What we're not yet ready to do is to say, you have no cognitive problems, but I am going to run these tests, and the results of those tests will tell me that you do or don't have Alzheimer's disease. That would, of course, be a very different kind of Alzheimer's disease. That would be an asymptomatic Alzheimer's disease, namely no cognitive impairment. But right now, the field isn't ready to put that out into clinical practice for reasons that I think are scientifically justified. But what we are able to do is, if you've got even mild cognitive impairment, to then push the workup to say that you have mild cognitive impairment, not dementia, and that mild cognitive impairment is caused by Alzheimer's disease. We can do that now.
Okay, but I mean, mild cognitive impairment. I mean, does anyone ever get mild cognitive impairment and not have Alzheimer's disease? I mean,
oh, absolutely, yeah. I mean, because the many different diseases that cause dementia, Lewy body disease, Alzheimer's disease, vascular disease, TDP-43, combinations thereof, FDLD, the many different diseases that cause dementia cause MCI as their initial sort of presentation of only mild impairments that over time become dementia. And the operative issue here is, dementia describes disabling cognitive impairments. So the operative word there is disability. Because of those cognitive impairments, you can't do things that you used to be able to do. And whereas MCI describes cognitive impairments that cause inefficiencies in daily activities. And all these diseases kind of pass through that period of time when there are inefficiencies. Where MCI becomes more murky is it's not just diseases that can cause MCI. Subtle but clearly noticeable impairments in cognition can be the sum of a host of insults on top of an aging brain that have nothing to do with disease, neurodegenerative disease. So a little bit of vascular disease, heart failure, if you will, lethal combination of medications for the brain, maybe a bit of an alcohol habit. Put all that together, you can get MCI, but it's not a neurodegenerative profile of MCI. Moreover, I actually think that some folks with MCI are kind of on the tail end of extreme aging in terms of the impairments that aging can cause to cognition. But I know that there are colleagues who would debate that point with me.
Okay, and then one of the things you talk about in the book is Alzheimer's versus Alzheimer's with dementia. Can you clarify? I mean, I have to admit, I'm not as much.
It gets confusing.
It gets very confusing
because nomenclature has changed and is going to continue to change. In fact, I would predict within about 10 years that Alzheimer's will be retired to describe only the people who have the particular pathologies.
So the plaque and the tangles and inflammation. Right.
And there'll be another term that's used as the overarching term. Here's the overall problem. If you have an organ, heart, lung, well, not the heart, lung, liver, breast, prostate, and it has mitotic figures that are causing tissue necrosis, those organs each have the same problem, which is called cancer. Rapidly dividing cells that are killing adjacent tissue and spreading. That's cancer. Different organs, different biology, different genetics, but it's the same problem, cancer. There is no overarching term that describes the different diseases that cause dementia or mild cognitive impairment or put you at risk of getting dementia or mild cognitive impairment. There's no cancer for these diseases.
Right.
And that's frustrating. Now, there is this term neurodegenerative disease, but that hasn't caught hold. So I think that haunts the field. And the term Alzheimer's has been used as the overarching term.
Right.
And that's where things get confusing.
Right.
So right now there's this phrase Alzheimer's disease and Alzheimer's disease related dementias. And that's supposed to be the umbrella term. But it's like, I thought Alzheimer's disease was the particular pathology. But so it's a nomenclature nightmare that the only way you can negotiate it is if you become like a Talmudic scholar and you're so deeply, I understand the nuance and the contradictions and, but for the rest of us, it's like, help me out here. So probably the useful point to make is just this. Dementia, disabling cognitive impairments, MCI inefficiencies, many different diseases can cause that. Alzheimer's is one of them, but it's not the overarching cause. That's where we're at right now in terms of our sort of nomenclature.
We're getting a question from Bill Hayden saying, what about Lewy body dementia?
Yeah, exactly. So Lewy body dementia, a very distinct disease in comparison. And we know that down to the molecular level. That is to say, the story is different. Waxing and waning attention, visual hallucinations, REM-based sleep disorder, kicking and thrashing in sleep, problems with attention, concentration, executive function, more so than memory, very distinct history. And if you autopsy that brain, because we can't visualize it in life, you will see alpha-synuclein aggregates. It's a funky protein in the brain that's aggregated. So a distinct disease with a distinct story. Robin Williams had it, the comic actor. And it causes dementia, and it is distinct from Alzheimer's, although there's a lot of overlap. Many people who have Lewy body pathology have Alzheimer's pathology and vice versa. A not uncommon autopsy report that I get on a brain autopsy is Alzheimer's pathology, alpha-synuclein pathology, and even other pathologies, particularly in someone who's over 75. But Bill, Lewy body disease causes Lewy body dementia. It's a totally distinct disease compared to it's not uncommon.
I'm convinced that Lewy body is one of the most misdiagnosed dementias because due to like a lot of people and feedback we get of misdiagnosis on our sites and people not recognizing.
Yeah, no, it's a very tough diagnosis early on because early on what you've got, people have a lot of anxiety.
Yeah.
And executive dysfunction. So it can easily be called, well, you've got anxiety and depression and aging, and et cetera. There is now a recognition that it has such pathologic overlap with Parkinson's that the Parkinson's disease community and the Lewy body community are starting to wonder, well, maybe we're actually the same disease because the pathology is the same. It's just presenting in different ways, predominant movement versus cognitive. That's an ongoing conversation. Really, the thing that's missing here, which Alzheimer's has, is you can measure the pathologies of Alzheimer's in life with scans, spinal fluid analyses. Right now, we're unable to do that in Lewy body disease. We can do a DAT scan that looks at a particular region of the brain, but we can't measure alpha-synuclein yet. Someday, I think we probably will.
I want to talk a little bit from your perspective about diagnosis. So tell us, because there is so much confusion from people who are first experiencing memory loss. What is it? How do you first of all, how do you diagnose someone? What are the key indicators that you're using when someone comes to you and says, you know, Dr. Karlawish, I am or it's usually
I'm worried about my memory.
Or it's usually the spouse saying something's wrong, but we're not sure exactly what it is. So
so the most important right now, the state of the art for diagnosis in the 21st century is no different than the state of the art in 1900 when Elias Alzheimer's met August Dieter, or the patient who came to him who was young and had dementia. The key thing was that she came in with Karl Dieter, her husband, and Dr. Alzheimer's was able to talk to the husband and find out the story. And that still remains really kind of important clinical tool, namely the ability to speak to people who know the person well, who can provide a collateral history about what they've noticed in that individual. And so, you know, cognitive testing is certainly very valuable, but I use cognitive testing to help explain what the history has told me. And that history comes from the person who has got the cognitive complaint, but also comes from that informant. And so really, even now in the 21st century, despite all of our tests and whatnot, we still need a good history, and that good history relies on someone else. So it translates into some very practical challenges at a good clinical practice. You have to have enough chairs, because if you don't have enough chairs, you can't fit everyone in the room to do the interview. Right. You have to have a waiting area that accommodates double the number of patients. And I'm not joking when I say this, because I've seen when we set up our memory center, they didn't give us enough chairs, and we would like fight each other for chairs.
Right. Yeah, it really is. I mean, a family effort, right? Like you need to get a lot of. So I guess one of the things I found interesting, because I actually find like the tests like the MoCA, when my mom was in an earlier stage of this disease, I used to give her the MoCA test a lot just to kind of check where she was at on a particular day. And what really struck me was the differences in her scores, right? Day to day. And this is again in an earlier stage. It wasn't now. I don't know what the outcome would be, but you mentioned the clock in the book, and you know, I kind of got it, because the clock was the one thing continuously she had a hard problem with. Tell us about those types of key indicators, because a lot of people now online, they go and they look like, I want to test my cognition. How do I know something's wrong? You mentioned in the Problem of Alzheimer's the significance of the clock. Tell us with your clinical practice, what is that?
Yeah, so the clock draw task is a fascinating test. I want you to draw me the face of a clock, fill in all the numbers, and show that it is 10 to 1 or 10 after 2 or 20 after 8. And you give the person the clipboard, piece of paper, to pencil, and watch them do it. And cognitive neurologists don't like the test, many of them, because it blends too many cognitive domains. It blends attention, concentration, visual spatial function, executive function, working memory. And their point is, well, failure to do it well doesn't really tell you what the problem is. And yet, you can kind of see how much it's visual spatial versus executive function. I find it a very useful test, though, because it's a performative thing. You actually watch the person execute it, and the errors and struggle is itself data as much as the final product. The final product, though, I was looking at my bulletin board because I have a clock draw here, if you bear with me. The final product is very illustrative to show the family, and this is a real patient's clock draw. You know, I can pick up the kind of problems that your family is noticing. When I had you draw the clock, you got really confused about what the time was and had trouble even putting in the hands. And it becomes a visual, if you will, to make real what is otherwise kind of surreal and hidden, because cognition is sort of kind of elusive, if you will. And cognitive testing is very sort of mysterious. So I find it a very useful visual as much as it is a measure, if you will, of cognitive impairment. Of course, all the more fascinating how to score this. you know, so it's very hard to sort of talk from one colleague to the other without just showing them the picture, which is fascinating. There's so much nuance and mystery in this disease.
For background, and this is what I've learned, correct me if I'm wrong, the clock is significant with cognition because it's multiple layers, right? We're looking at numbers that don't necessarily correspond, like 10 past 2,
Right, just if you think about like 10 past 2, you have to engage in this abstraction of, well, 10 past 2 is actually the 2, so the 2 means 10. Your brain's working there, actually.
Right.
And that's why I think it is a very interesting test of a variety of cognitive abilities, because it requires these abstractions and then a representation on the visual page. So I think that's, by the way, I researched the history of the clock draw. It's a mysterious test. It's first mentioned in about 1970, don't quote me. And if you find the original paper, there's no prior to it. There's no real prior studies and development. It was just sort of pops up in a paper by a psychiatrist who starts using this task as a way to diagnose problems with executive function and parental mediated executive function in particular. So it's sort of it just sort of comes out of nowhere. It doesn't have a clear history. It's fascinating.
It is fascinating, actually, but it's like a really, it's probably one of the most commonly used diagnostic tools, right? Is that fair to say?
It's very common in practice because it is so sensitive to picking up executive dysfunction and visual-spatial dysfunction. Now, having said all this, if there's one key pearl I can relay is no one test measures that you have cognitive impairment. And I can't stress enough that cognitive testing is only as good as the testing and the tester who administers it. And it is very dependent on a person's levels of literacy, acculturation, and test-taking abilities. And so cognitive testing remains this very kind of delicate art. And the notion that there's the test you give, and that test will tell you whether or not you have dementia or MCI, or certainly tell you have Alzheimer's, is just that. It's a notion. And I find myself doing a lot of education with patients and families, like, no, there is no one test. And I know you did okay on that test, but it's the sum of everything that I'm hearing here, which has me concerned that this just isn't a bad day of test taking, for example.
Right. One thing that fascinates me is as we interview people diagnosed with dementia, different types of dementia, I'm starting to see patterns in, like, I love asking the question in hindsight, was there something you noticed that could have been wrong? And I don't mean the time when they get lost, coming home from the store, because by then they're going to go see you, right? That's the time. But when we're talking about early signs, from your research and from the patients you've seen, are there things that you think that possibly we can point to that happened maybe 5-10 years before for diagnosis?
Yeah, don't quote me on the 5-10 year thing, but so in the book, I profile the work of a physician at Oregon Health Sciences University, Jeff Kay. And what Jeff did was realize that everything I've been talking about, histories from an informant, clock draws, it's all indirect. It's all one step removed from what we want to know about, which is how is the person functioning in the world, and are they changing in their function on tasks that require cognition? And what Jeff did, that was his revelation. He said, well, why don't I just wire up people's homes? Why don't I just put all kinds of sensors that detect their ability to do daily activities that are cognitively intense? Well, what are those activities? Driving, using the car, managing your medications, using your computer. And guess what? Jeff has found that long before a label is put on someone, he can show trends in your ability to do those daily activities. So, for example, he shows in the months, years prior to the diagnosis, people are driving less. They're shrinking the distances they take. Also, the quality of their driving is changing, running red lights, going too slow, or going too fast. He shows long before an onset of mild cognitive impairment diagnosis, people are using their computer less, those who go on to develop MCI, just less time on the computer. So the point I get at in the book is what we really want to do is not have all these fancy tests and people playing with the MoCA and the president of the United States asking his opponent, what's your MoCA score? I'll show you mine if you show me yours. That got a little weird. What you want is you want the White House wired up to look at how the residents are doing in terms of their use of the computer and other cognitively demanding activities, because that's what's going to detect the onset of cognitive problems. And that's I profiled Jeff because I think that kind of intervention, that kind of technology really is not just the future for detection, but after detection for monitoring, right?
Right.
Because what you want to do is pick it up early, get treatment going, and then see how people are doing. And avoid the disasters like, oh my God, the checkbook's in total disarray, or, thousands of dollars have been fraudulently transferred because the person was making mistakes, etc. You want a monitoring system in place.
So do you believe, this is an area of research that needs to be explored more, but continuously is so. Do you believe when you have a diagnosis of early stage Alzheimer's or MCI, there are lifestyle things that you can do to slow this disease down?
Well, there are proven lifestyle interventions that reduce the risk of developing dementia.
Once you have a diagnosis.
Yeah. So the data on individuals with a well-classified diagnosis of dementia and lifestyle interventions is a thinner set of data. Having said that, I think most of us would say if I have a lot of cardiovascular disease that's untreated, it's probably going to worsen my dementia. Okay. If I'm socially isolated and have untreated depression and anxiety, it's probably going to worsen my dementia. And so I think there's good reason to think that those things should be identified and treated. I personally don't feel I need randomized controlled data to say I should take care of those problems in order to help maintain brain health.
Right. So we just have another question coming in saying, I saw a trial planned by Apple and Biogen designed to monitor for Alzheimer's. Will the Penn Memory Center be participating in this study?
Not that particular one. Yeah.
So why is early detection so important from taking care of the person, from let's say we have the capability in the next year or two to really see the signs coming before there's symptoms. Why is that so important?
Well, to see the disease before there are symptoms, that is to say, to diagnose it the way we diagnose heart disease with blood tests and blood pressures, even though you're feeling fine, that's tightly conjoined to I'm now going to give you an intervention that will reduce getting sicker, because that's a basic, I think, point of societal value. Granted, some people would say, well, I want to know that information so I can plan, and I value knowledge, but those are matters of personal taste. And I think in a healthcare system, matters of personal taste don't have as much priority as clear benefits to a population regardless of your personal taste. Of course, you could choose not to take the treatment. So what's been missing and still missing in the Alzheimer's field is a treatment that I can prescribe with great confidence, that like a statin drug or an antihypertensive drug, that I can say with confidence, if you take this, you will reduce the chances of developing dementia down the road. Someday we'll have a treatment like that. They're in the works, but they're not yet studied. But I would, go ahead.
No, go ahead.
I would say, though, there's a strong warrant in individuals who are having cognitive complaints and problems to get that evaluated. And I do believe, for example, that the mild cognitive impairment diagnosis is a useful diagnosis to identify people with cognitive problems that are causing inefficiencies and put them at heightened risk of developing dementia. And the reason why I think that that's valuable, and I've had a change in part on this from earlier, but the reason why I think it's valuable is this is a disease of autonomy. And I want to give people the chance to arrange how they live to prevent the disasters of dementia, not the end stage disasters, but I'm talking about the disasters like the screwed up checkbook, the mistaken medicines, the poorly treated diabetes, the social isolation, and the failure to build trusting relationships with other people who are going to help you. If you wait until you have dementia, first of all, you will have suffered harms to get there. And secondly, the nature of some of the cognitive and behavioral changes that patients have oftentimes make them very suspicious and unable to take help in. And so there's a real value to preserve your autonomy, to actually surrender some autonomy to other people early on so that you can maintain some degree of independence. And that's a very ironic problem that this disease presents us. We want to be independent, but I would argue to stay independent, you have to surrender some independence. It's an irony, but I think it's an essential thing.
One of the things that I really like about the problems with Alzheimer's is that when you write, you give us a timeline. And one of the things, we were talking about this before, that really jumps out at me was like, oh my gosh, like only in the late 70s, early 80s, were we really taking cognitive, degeneration seriously. I mean, we really, before that, I mean, there were history of cases, but the science really wasn't focused on it. Like, tell us a little bit about the historical perspective, and given what you bring up in the book, what does that mean for where we are today in finding a solution to Alzheimer's?
Yeah, no, I mean, the history of Alzheimer's disease, as we understand it as a modern disease, is very different than, say, the history of cancer and heart disease. Really, the field only got going in around basically 1980, which isn't that long ago. It's less than half a century. Prior to that, it was kind of the dark ages. And the reason why it was the dark ages, where really no medical discipline, neurology, psychiatry, geriatrics didn't even exist, was interested in dementia, was because of really two events. Number one, early work that had been done in Germany in the early part of the century, 20th century, ground to a halt because Germany ground to a halt by about 1918 when they lost World War I, descended into social and economic chaos, dark nationalism, and vicious anti-Semitism. All those factors worked together to essentially shut down the research that was going on in Germany. And most of the early Alzheimer's research, most of the early research on dementia was being done by psychiatrists who were German. And so the collapse of Germany collapsed that work. Much of the 20th century was kind of a loss because they were all sort of just gone. And Freudian theories took over. Freudianism, psychodynamic theories of mental illness dominated psychiatry for about half the 20th century, particularly in America. And that's relevant because after World War II, America was the dominant power. America kind of set the standards for how things advanced in science. I'm not trying to diminish the role of other countries, but the pace of discovery and invention really was in America. And American psychiatry had absolutely no interest in dementia. It was interested in psychodynamic theories of illness and their treatment, and dementia was not amenable to that. Neurology was interested in lesion-based diseases, so it wasn't great. So dementia just was sort of hidden. But there's another key event as well, and that key event is culture. Beginning of the 20th century until about 1980, and even after 1980, the idea that an adult has a sense of identity that we ought to respect and support, namely support their autonomy, was just that. It was an idea that wasn't universally held. I mean, my mother remembers in 1961 being told by the bank, you can get a credit card if your husband gives you credit. I mean, let alone that she can't do math and, jobs like law and medicine weren't available to her. Well, until society widely recognized that self-determination is a universal human value, not a particular quality of certain races, genders, etc., until that transformation in culture occurred, it was hard to see older adults getting forgetful and not being able to self-determine their life as terribly bad because, well, that's just aging and whatever. Now it's like, no, that's wrong. I don't want to lose my autonomy. And if the scientists are seeing plaques and tangles in my brain that might be causing it, well, let's call it a disease and take care of it. And so that's what gave birth to Alzheimer's disease. But that wasn't until 1980 because the universal respect for autonomy wasn't really possible until then. Even now we have debate about it. So that's why it's a very late disease, those social and cultural events.
It's interesting. So do you think that there's we just understand more, or are there more cases of dementia? I mean, we always quote that figure, there's going to be triple the amount by 2050 or something.
Yeah.
But are we just getting better at diagnosing it?
Well, there's no question that the numbers increase, the more sensitive we are in diagnosing it. And there is no question that, there are more older adults now than there were in 1900. And dementia's one of its chief risk factors is chronologic age, particularly after the age of 80. And so, yes, there are more people with dementia because there are more older adults. But as long as there were older adults, there were people with dementia. We just didn't think of it as the result of a disease. We thought of it as the result of extreme aging, and we called it senility. And medicine has had and still has absolutely no interest really in aging. If it's not a disease, medicine doesn't deal with it. It makes sense. If it's not a disease, why should we deal with it? But once something's a disease, medicine steps in and is all gung-ho, as long as it can make as a business model. And for the longest time, dementia was just part of aging, namely it was senility. So too was caregiving.
Yeah.
So the role of the caregiver is a very modern role. Humans have been caring for each other since the beginning of civilization. In the Bible, the book of Ruth in the Old Testament is the story of Ruth, who was caregiver to her mother-in-law, Naomi. Naomi was widowed. Ruth was widowed. Naomi says to Ruth, well, I guess you're probably going to go back to the village you came from. She says, no, I'll stay here. I'll take care of you. And she cares for her mother-in-law through poverty and struggle. And that's what the book of Ruth is about, until she meets a man and the man marries her and everything works out well. Well, Ruth is never called Naomi's caregiver. She's just a good daughter-in-law. The word caregiver only came into existence around 1980. Before that, there was just families doing what families do, and it was not recognized as a distinct role with an economic and social cost upon the family. So all this stuff is very modern.
So, and that's what's fascinating about your book is that, when you think of it in the context of, we really weren't like taking this disease very seriously until really the late 70s, early 80s, we weren't
taking it seriously as a medical problem or a social problem. It was a private family problem unless someone was very mentally ill with it.
So given what we know today, I mean, 1980 wasn't that long ago, right? So given what we know today, what do you think about the progress that we've made?
I think, as much as everyone complains, there's no treatment, there's no cure, well, there won't be a cure, but there's no effective treatment. I gotta say, you do realize that it wasn't until 1980 that we recognized this disease. It wasn't until about 2010 that the federal government finally kicked in enough money to really do the research. It wasn't until 2000 that we developed technologies that could visualize the disease in a living human instead of waiting until you died and had a brain autopsy. And I was able to interview those researchers who did that groundbreaking work to develop amyloid imaging. So it wasn't until 21 years ago that we were able to visualize at least part of the disease in a living human. That's not a lot of time. I mean, that's like 20 years is not a lot. Granted, big things can happen in 1 year. Witness the events of the last year in the world. So my point is that there has been progress, but the progress has been uneven. Meaning, great progress in diagnostics. We're beginning to make progress in therapeutics. Absolutely lousy progress in America in the quality of care and the delivery of care. I mean, that's a scandal, I think, in America.
What do you make of, we had another question about this, of the blood tests coming to market. We know some of them are being used. We have a viewer who's asked, would you recommend yearly screening by a PCP with one of the Alzheimer's blood tests?
Oh, God, no.
Okay,
that's like giving a teenager beer. There's a six-pack.
So you wouldn't, but they're coming to market.
Well, they are. No, I wrote an essay with my colleague Emily Largent at the University of Pennsylvania. I think it's only a matter of time before a blood test for Alzheimer's pathology, not dementia.
So
I think it's only a matter of time that they become a direct-to-consumer test.
Right. In Walgreens, in the drugstore, we can purchase it and maybe prick our.
Yeah, and there's a good reason why. Think of the tests that have become DTC tests. They're tests that appeal to people who have intense desires to self-determine their life, and they want control. I want to know if I'm pregnant, and I want to know now.
Right.
I'm not going to wait till some doctor tells me I'm pregnant because I'm going to do something. I want to know if I have HIV because it's a very private, personal matter. I want to know what genes I have because I value that information for myself and it's private. I think Alzheimer's fits into that category of the kind of test that appeals to some people for a direct-to-consumer test. And so I would predict there'll be direct-to-consumer tests for these Alzheimer's markers. I don't like that idea. I think it removes kind of not because I don't trust people with information, but because in America, I'll be blunt, when that consumerism spirit takes over, we tend to use these things, again, I use this metaphor, like teenagers in a liquor store. We just don't know when to stop drinking, and we think we can do it, but we're given bad advice, we're dumped with information, and we don't live in a society that is designed to support people who are disabled or at risk of disability. You can be fired, you can lose insurance, you can be stigmatized. This is not a nurturing society that fosters solidarity. And so the deep irony of these direct-to-consumer tests is, I'm going to give you knowledge that empowers you in a culture, in a society that doesn't support you. That's pretty kind of stupid.
Yeah, and when you put it that way, that does, it does make you think. Yeah. And, the question too is, like living life too is a great part of cognitive health, right? It's like socializing and everything.
Yeah, I think my advice to people is go to the Global Council on Brain Health, produced by AARP. They've got great advice on brain healthy activities, both what's been shown to work and what's a waste of time. Go to look at that, live that life, and then organize a trusted network of people that watches over you and you watch over them, not one person, but others. And kind of live your life like, I probably am going to have some cognitive impairment. And so every day, every year is precious. I think that's a way right now that kind of balances both being planful and thoughtful without becoming obsessed about the fear of dementia. If there's a therapy that could prevent things or slow it down, that would change the equation. But we don't have that right now.
Okay, so are you in the camp that you're not going to have a one pill cures all? Is it going? When do you think we'll see a cure for Alzheimer's, and what is it going to look like?
I think planning on a cure for Alzheimer's disease is like planning your retirement with lottery tickets. You could buy a whole bunch of lottery tickets and say, well, I'm set for my retirement. Look what I got here. And you're right. You may win big. And if you win, you will win big. But you're not going to win. You're not going to win the lottery. And I think that's my thought about thinking, well, we're just going to cure this disease and we'll be done with it. Because first of all, back to the beginning of our talk, the gentleman who asked about Lewy body disease, there are other diseases that cause dementia. It's a very heterogeneous disease in itself. And the idea that you would, quote, cure all those causes is, I think, a little too ambitious. We should, though, anticipate a future where we can control that natural history. Some people will benefit tremendously. Some people will benefit a little bit, and some won't. And isn't that the story of like cancer? In my family, I have family members who have cancer and are now, I think, cured. And I have family members who are dead.
Right. Well, thank you so much.
You're welcome. It was fun.
Karlawish, and I'm going to give your book another plug because I think it's really worthy. We'll post a link. The Problem of Alzheimer's. It really is worth a read. It's super interesting to look at the history, how the science, has developed to where it is today. So thank you so much for writing that.
You're very welcome.
And to our viewers, if you have more questions for us, just leave them in the chat. We can come back to Dr. Karlawish. He's now appeared twice and hopefully will appear again in future. But
I look forward to being back. And folks, you can visit my webpage, jasonkarlawish.com, and there you can send me little notes and read my other writings and other things too. So it's just myname.com, jasonkarlawish.com.
Perfect. We'll attach that link to this video as well. Thank you so much.
Thank you so much. Bye, everyone. Take care. Enjoy the summer.